The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone, and welcome to today's program, an update on pediatric immune thrombocytopenia, differentiating primary ITP, IPD, and PID. My name is Dr. Racheal Grace, and I'm an associate professor of pediatrics at Harvard Medical School and a pediatric hematologist at Boston Children's Hospital. I'm the director of the Boston Children's Hematology Clinical Research Program, and one of my main areas of research and clinical focus is in immune thrombocytopenia. I'm the director of the Coordinating Center for the ITP Consortium of North America, which is a collaboration of investigators who focus on making progress in the care of children with ITP. I will be moderating today's program. The Foundation for Women and Girls with Blood Disorders mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every life stage. To this end, we aim to provide education to healthcare providers on the medical consequences and unique issues for women and girls with blood disorders. Since its inception, the Foundation has focused on realizing its vision through these objectives, as you can see displayed. To ensure the best sound quality during our program, all attendees will be muted. However, you'll have the opportunity to participate in a question and answer session with Dr. Lambert and myself at the end of the program. You can submit your questions during or after the presentation portion via the chat box in your control panel on the right-hand side of your screen, and we'll address them during the Q&A session at the end of today's presentation. I'd like to introduce Dr. Michele Lambert, an associate professor in the Department of Pediatrics at the Perelman School of Medicine at the University of Pennsylvania. And Dr. Lambert and I co-authored the paper today being reviewed. We're grateful for this opportunity to share our work. The next few slides detail our accreditation process. In support of improving patient care, this activity has been planned and implemented by SignMed and the Foundation for Women and Girls with Blood Disorders. CME will be provided to physicians and nurses, and a follow-up email will be sent to attendees explaining how to obtain 1 hour of CME and CE credits for the program in its conclusion. You'll receive an email after the program's conclusion with the evaluation and details about receiving CME credit. We would like to thank SOBI for their support of this program. Before we begin, we would like to do a quick poll to see how many people are joining us today with others. Please take a moment to answer the poll question on your screen. We'll just give you a few more minutes or seconds. All right, thank you for the responses. Please close the poll. All right. I will now turn over the call to Dr. Lambert for her presentation and remarks. Thank you, Dr. Lambert.
Thanks, Racheal, for that introduction, and thanks everybody for joining us today. I'm going to talk today about this paper that Racheal and I wrote, and basically we're going to describe the key features of patients with thrombocytopenia that warrant further diagnostic evaluation for inherited platelet disorders or inborn errors of immunity, explain the indications for and utility of molecular analysis for pediatric patients who have thrombocytopenia, and delineate a diagnostic and therapeutic algorithm for pediatric patients that present with thrombocytopenia. So we'll go through these things, but we're going to do it in the setting of a bunch of case presentations. So case one is a 3-year-old healthy female who presents with acute onset of petechiae and bruising after an upper respiratory infection. She's had no mucosal bleeding symptoms, and aside from skin findings, she's got a normal physical exam. She does have a little bit of bruising and petechiae. She has laboratory studies that are normal except for a platelet count of 5, and her peripheral blood smear shows pretty normal red cell and white cell morphology and just a paucity of platelets, and those platelets are large. So let's see what you guys would do. Besides a CBC and peripheral blood film, what labs would you order at presentation? Okay. Lucy, can I see the results? Awesome, fabulous. So it looks like about 40% of you said none of the additional testing, and about half of you said some of the additional testing of quantitative immunoglobulins, DAT, and antiplatelet antibodies. So let's go back and talk a little bit about what to do. Come back. Here we go. So, come on. Normally in a child who has ITP and it's newly diagnosed, we wouldn't necessarily recommend a lot of additional testing at that time. Although there are some people who might do immunoglobulins before they do IVIG if she were to have significant bleeding symptoms. I'm not sure that I would necessarily treat that patient at this time, and so I think I probably wouldn't do very much more than just observe that patient for a period of time. But now, if this patient continued to have active ITP for the next 5 years, what labs would you do, if any, at that time to further evaluate the patient? All right. Can we see the result? Let me see the results. It looks like the majority of you would do some or all of the above testing, including full immunophenotyping, genetic testing for immunodeficiency, and antibody evaluations for rheumatologic disease. And only about 3% said that they wouldn't do any of that testing. So let's talk a little bit about immune thrombocytopenia. So historically, idiopathic thrombocytopenic purpura, but we now know that it's immune mediated in every patient who has ITP, and not every patient has purpura, and therefore the name was changed back in 2009 to immune thrombocytopenia. So this is immune-mediated bleeding disorder of platelet destruction, and a paucity of platelet production to compensate for that platelet destruction. So it's both a megakaryocyte problem and a problem of platelet destruction. And there are antiplatelet and anti-megakaryocyte antibodies. There's impaired regulatory T cells and B cells. And there's T cell mediated destruction and T cell toxicity that also contributes to the immune destruction of platelets that we see. And in some patients, this T cell mediated destruction actually plays a predominant role rather than the B cell destruction. It manifests with skin and mucosal bleeding, and patients really do have quite impaired quality of life and can present with significant fatigue. In children, this disorder is most often transient, but management really needs to be individualized for patients in order to take into account those things that are most important and ensure the best outcomes. Okay. So immune cytopenias can be classified as primary or secondary. In primary immune cytopenias, the underlying reason for that immune destruction of the platelets is really idiopathic. We don't understand why the immune system gets confused. There's just a primary loss of tolerance. In secondary immune cytopenias, there is a underlying driver that causes that loss of tolerance, either medication related, vaccines, infections can do this. There are primary immune dysregulation disorders or inborn errors of immunity that are related. Individuals who have Evans syndrome or other autoimmunity can would be considered to have secondary ITP, or patients who are post-stem cell or solid organ transplant and have dysregulated immune system as a result of that can have secondary immune cytopenias. And the diagnosis of ITP is a diagnosis of exclusion, but usually it doesn't require a ton of laboratory or other testing in order to make the diagnosis. So really, we want to, on history, make sure there are no systemic symptoms or other syndromic symptoms that might suggest a familial thrombocytopenia or an inherited thrombocytopenia. Typically, patients don't have any other symptoms other than maybe fatigue or things like that, and skin and mucosal bleedings. Physical exam findings are generally normal. Patients will have normal vital signs. They may have bruising and petechiae. They may have oral purpura, but they typically do not have lymphadenopathy or organomegaly, especially in primary ITP. Laboratory findings, complete blood counts will show an isolated thrombocytopenia, and reviewing the peripheral blood smear will show large or giant platelets and normal red and white blood cell morphology. And it really is good practice to review the smear or have somebody in the lab review the smear and confirm that platelet count and let you know that platelet count is real and that there are some large platelets. Bone marrow is not needed for the vast majority of patients with ITP, and even if that patient doesn't respond to first-line therapies, in many cases a bone marrow doesn't really add anything to that diagnosis. And a way to confirm the ITP diagnosis is to administer something like IVIG or corticosteroids, and patients will respond. And so that might be a way to confirm an ITP diagnosis, but is not necessarily a reason to administer those therapies in the absence of other reasons to give those treatments. In adults, especially with ITP or older adolescents, you might consider additional testing in order to look at other things that might be contributing to or driving ITP. H. pylori testing in certain areas, particularly where there's high prevalence of H. pylori infection, might be helpful, as there's some data that suggests that treating H. pylori infection, especially early on, can lead to a lasting remission. Consideration of hepatitis C and HIV testing, particularly in patients who have risks for hepatitis C or HIV infection. And thinking about doing an ANA and thyroid testing, especially if patients have any other symptoms that might make you think about underlying rheumatologic or thyroid disease. And then thinking about whether or not to do a DAT, the International Working Group Consensus Report suggests doing a DAT as part of your workup for ITP. There is some data that suggests there's an increased likelihood of chronic ITP, and it might help you to decide whether or not to use a second-line therapy for a patient who had a positive DAT. However, it can be positive in 20% of patients with ITP, and it's not always associated with hemolysis. And so if you do do a DAT, you probably also need to make sure that your patient isn't hemolyzing and get an LDH, bilirubin reticulocyte count, and just be sure that you really understand what that test is telling you. And then making sure that you understand what the implications of that test are if you're going to send it. Additional diagnostic testing that is not recommended by guidelines at this time, but can sometimes be helpful, especially if you're trying to decide if your patient has an underlying bone marrow problem versus immune-mediated thrombocytopenia are things like an immature platelet fraction and a mean platelet volume. In patients who have immune-mediated thrombocytopenia, the immature platelet fraction tends to be significantly elevated compared to patients who have bone marrow failure or malignancy or other causes of thrombocytopenia. The caveat to this is that patients who have dysthrombopoiesis, so Bernard-Soulier syndrome or May-Heglin, MYH9 related thrombocytopenia, can have incredibly high immature platelet fractions. And this is because the immature platelet fraction is in part dependent upon size of platelets and on RNA content. And when you're not making your platelets well because you have an underlying cytoskeletal defect, that immature platelet fraction can be quite elevated. So an IPF of something incredibly high, greater than 30%, definitely makes me think about an inherited platelet disorder and not just ITP. And then there's conflicting data currently about whether or not the immature platelet fraction can predict bleeding. A study in 2015 suggested that perhaps having a higher immature platelet fraction was associated with a increased risk of bleeding and a higher bleeding score. And then a study that we did that looked at a totally different population of patients suggested that patients who had an elevated immature platelet fraction actually had a lower bleeding score and a lower bleeding severity. So the data is still unclear about the immature platelet fraction and bleeding severity. I think there is an ongoing study right now trying to assess prospectively, because both of these studies were retrospective, whether or not the IPF can predict future bleeding. Ooh, sorry. And then antiplatelet antibodies have also been assessed in helping to make the diagnosis of ITP. At this point, they're not routinely recommended. The specificity and sensitivity of antiplatelet antibodies has significantly improved, and especially the antigen-specific antibody tests. The specificity has definitely improved for these tests, but it's only about 60% sensitive. They might be associated with future disease course. The TIKI study, which was designed to look at IVIG and the future development of chronic ITP, as a secondary outcome, looked at GP2B3A antibodies and IgM and IgG, and found that IgM GP2B3A antibodies were associated with younger age at diagnosis and a faster recovery, but they were really quite transient and were present for less than a week at the time of diagnosis. And that IgG antibodies directed against 2B3A were rare, but were associated with an IVIG response, and therefore might predict that IVIG would be a good therapy for those patients. Overall, though, it's really hard to know exactly what to do with antiplatelet antibody testing, and generally is not recommended outside of the setting of a clinical trial. So what about doing immunophenotyping in patients who have ITP, and particularly patients who have chronic ITP? I think one of the reasons that this becomes an important question is when we look at patients who have primary immune deficiency, there is a significantly increased risk of immune cytopenias in the immune deficiency patient population. So there's 120 times higher rate of immune cytopenias than the general population in patients with inherited errors of immunity. And 30% of these patients will have immune cytopenias. and these immune cytopenias are associated overall with lower survival. And so, and that may be because these patients with inborn errors of immunity are then getting immunomodulation in order to treat their immune cytopenias, or it may just be a predictor of severity of disease. But in any case, there certainly is a clear association in patients with immunodeficiency of autoimmunity and inflammation and immune cytopenias. And therefore, it's really important to think about this in your patients, particularly if they don't follow the expected course of ITP and resolve quickly. And when we think about immune defects associated with with immune cytopenias, we think about patients looking at their immune profiles. If we look at the immune profiles and we find abnormal B cell numbers or functions but normal IgG levels, we tend to see immune cytopenias and autoimmunity and lymphoproliferation. And these are the ALPS-like syndromes, the autoimmune lymphoproliferative syndromes. And these tend to be associated with specific monogenic defects that regulate lymphocyte proliferation. Things like FAST and FAST ligand, and then other genes that can facilitate lymphocyte proliferation that cause the ALPS-like defects. CTLA4 and LRBA cause an ALPS-like phenotype. CASP8 causes an ALPS-like phenotype. It's important to identify these disorders because they do respond to immunomodulation very nicely, and you want to avoid splenectomy in these patients, even though they can have very large spleens, because that can really increase their risk of infection and other complications. Patients who have CVID-like presentations will have worsening B cell function over time, will present with low IgG levels. They can present with cytopulmonary infections, but that may be a late manifestation and may not happen until they have really low IgG levels. And earlier on, they make ineffective antibodies, and so they can present with immune cytopenias and autoimmunity. And these patients can also have lymphoproliferation and can get quite large lymph nodes and lymphadenopathy as well as a part of their CVID-like disorder. And then there's also late onset immunodeficiency syndromes that fall under the more combined immunodeficiencies and tend to be hypomorphic mutations that, when they're fully dysfunctional, result in a SCID phenotype. But if you have a hypomorphic mutation, instead you end up with these late onset combined immunodeficiencies. And these patients are at risk for significant infections. But again, those infections may not manifest initially, and they may manifest initially with immune cytopenias and other autoimmunity. So identifying that primary immune deficiency can guide management. If you identify, for example, STAT3 mutations, you might use a JAK inhibitor or an IL-6 inhibitor. If you identify FOXP3 mutation, you might do tacrolimus or go to transplant. If you find LRBA deficiency, you might also consider that patient for stem cell transplant or do targeted therapy with a beta-sept, or the same thing if you find CTLA4 haploinsufficiency. If you find other immune deficiencies, you may refer that patient for stem cell transplant, or you might do targeted therapies. And so I think it's really important to think about these underlying errors of immunity, inborn errors of immunity, because again, targeted therapies are available for some of these disorders, and some of these disorders really do better with stem cell transplant in order to improve the life expectancy. So thinking about a couple of different cases of kids who have ITP, if I saw a 15-year-old with newly diagnosed Evans syndrome and presented with immune neutropenia, ITP, was DAT positive without clear hemolysis, but also had a history of Hashimoto's and celiac disease, dad's got a history of autoimmune hemolytic anemia, that patient to me really needs an evaluation for an inborn error of immunity. A 9-year-old with chronic ITP for the last 4 years, and there's a family history of 2 siblings who have type 1 diabetes. That patient, I think about potentially having an underlying inborn error of immunity. Or a 4-year-old with chronic ITP since he was 2, who's been refractory to multiple ITP-directed therapies without a relevant family history, but really just isn't responding to the typical ITP therapies. That patient, I think, deserves a workup. So anybody with Evans syndrome, either 2 immune cytopenias concurrently or historically. So they had autoimmune hemolytic anemia and then 2 years later present with ITP, or the other way around, or they have autoimmune neutropenia in early childhood and then later on present with ITP. If they have ITP that's refractory to multiple therapies, chronic ITP for more than 2 years, and I really start thinking about it once they hit that 1-year mark, because it can take months to get insurance approval for some of the molecular testing. And so when they hit that 1-year mark, I start talking to families about immunophenotyping and then about molecular testing. Immune cytopenias and family history of immune cytopenias, and a family history of other autoimmunity, or if there is a family history of other autoimmunity. So if that patient themselves has other autoimmune disease or has a family history of other autoimmunity. And for immunophenotyping, we look at T, B, and NK subsets, T regulatory cells, and naive and memory B cells, and then consider looking at follicular T helper cells as well. You'll want to do functional assays, so you'll want to do a proliferation assay to look at T cell functional studies, and you'll want a cytokine panel. If you can get NK cell function, you'll want to get that, although that can be quite variable and sometimes difficult to obtain a really good sample and assay for that. You'll want to get immunoglobulin levels and a soluble IL-2 receptor, soluble CD25, and look at vaccine titer responses, and then think about genetic testing and whether or not you want to get a targeted panel, an exome, genome, or a microarray may depend on what you see in that patient themselves and the family history. So let's talk about a 12-year-old male who just moved to the area, and now it's time for everybody to wake up a little bit, because I'm going to ask you guys to give me some advice on what you do for this patient. He just moved to the area with his family. He transfers as a new patient to your practice. He's been followed for ITP since the age of 2. That's actually his first CBC. He's generally had a platelet count between 60 and 90,000, and his other blood counts and physical exam is pretty normal, although he does have bruising and petechiae on exam. His father also has a diagnosis of ITP. A peripheral blood film reveals a normal morphology with occasional large platelets. So would you think about genetic testing in this patient or not? Would you think about evaluation for primary immune disorder, or think about an inherited platelet disorder? This patient does have reasons to think about an inherited platelet disorder. If you don't have a platelet count that's ever been normal, if you have moderate thrombocytopenia, if you have a parent with thrombocytopenia, if you have uniformly large platelets or an immature platelet fraction, I generally start thinking about it above 25%, certainly above 30%. If you have abnormal platelet granules or neutrophil inclusions, then I definitely think about inherited platelet disorders versus primary immune deficiencies. And so when I'm thinking about thrombocytopenia in a child, I think about the age at which that child is presenting and whether or not that patient has other abnormal findings on their peripheral blood smear. So do they have macrocytosis or other cytopenias? Sorry. That might make me think about bone marrow failure syndromes or aplastic anemia. Or is there platelet clumping? Are there schistocytes? Does the patient have splenomegaly? Did they just start a new medication? Or do they have like no prior normal platelet counts? Is their platelet count sort of moderately low? Or do they have a parent who also has a low platelet count or a history of chronic ITP? Then I think about inherited platelet disorders. And in those patients, I think about doing, flow cytometry and platelet function testing. And then I think about molecular testing in those patients as well. But then I think about doing an inherited platelet disorder panel. All right, so let's talk about a 7-year-old male diagnosed at 5. His platelet count's generally 20 to 30,000 with minimal bleeding symptoms, occasionally has some petechiae. The parents report that he takes daily naps after school. His 5 and 10-year-old siblings are much more active. They actually argue about going to bed, and the 7-year-old really doesn't. He doesn't participate in any organized sports and hasn't required any regular treatment for his ITP. His peripheral blood film reveals normal more with occasional large platelets. So what would your discussions with the family now cover? Fatigue is a symptom of active ITP and possibly an indication for therapy. Additional behavioral health evaluation is warranted, as this is definitely not related to ITP. There is an association of depression and anxiety in pediatric patients with ITP. Some or all of the above or none of the above. So let's see what people said. So about 60% of you, 65% of you said some or all of the above, and about 30% said fatigue is a symptom of active ITP and possibly an indication for therapy. So current guidelines do not recommend treatment based on platelet count alone, but they do recommend consideration of health-related quality of life and secondary ITP symptoms beyond bleeding as a possible indication for treatment. And several studies have shown that fatigue is common and health-related quality of life is poor in patients who have ITP. There's an association of depression, anxiety, and psychological symptoms that's definitely been shown in adults, and there's although there's a paucity of data in pediatric symptoms, or in pediatric patients. For fatigue, though, there's definitely emerging data about how common fatigue is in pediatric patients. And in a study that we did in the ITP consortium, we found that fatigue was really quite common, with 54% of patients reporting fatigue at diagnosis, and this occurred across all age groups, and that fatigue improved with therapy. Although some therapies might be better than others to help improve fatigue, it definitely did seem like there was an association between ITP and fatigue, and it really didn't matter how old you were. You could be 3 years old and have fatigue, or be a teenager and have fatigue. So I think in this patient with ITP and a low platelet count, but not so low that necessarily would warrant therapy by itself, but because of the minimal bleeding symptoms, but significant fatigue, I would ask that family how they're feeling about it. And when you do that, this young man actually reported significant anxiety regarding risk of bleeding and some depressive symptoms due to feeling very different from his peers, because he was afraid to go out and run around with everybody because he was afraid that he was going to have more bleeding, or that something bad was going to happen to him because he had ITP. And so in this kid who's reporting significant fatigue as well as anxiety and depressive symptoms, what second-line therapy would you consider? I'm taking the decision of treating him for his ITP out of your hands. I'm going to say we're going to treat him for his ITP. So would you consider a TPO receptor agonist, rituximab, an oral immunosuppressant, splenectomy, or none of the above? All right. So it looks like about half of you responded with a TPO receptor agonist, about 30% with rituximab, and 22% with oral immunosuppressants. Nobody picked splenectomy. And so let's talk about rituximab. So rituximab has about 50 to 60% early responses with about a 20 to 35% sustained response in pediatric and adult patients. It is off-label for ITP, and it doesn't have an indication, although we use it quite a lot in ITP. And is generally well tolerated, but does have a risk of infection, and has a small but not zero risk of prolonged hypogammaglobulinemia post administration in patients who are treated with rituximab. There's no dosing studies that are available, and so it's possible that we're overdosing because we do use generally either rheumatology dosing for lupus or lymphoma dosing for rituximab, and that may be much higher than we actually need to do for ITP. We get B-cell depletion often with a single dose, but we haven't actually done studies to show that, definitive studies to show what the right dose for ITP is. It's not a benign therapy. There's serum sickness, infection risk, and infusion reactions, particularly the infusion reactions that occur with the first dose, which can be anaphylactoid and quite frightening. And about 30% of patients in some studies can have persistent hypogammaglobulinemia, which is associated with younger age at administration, if they have IgA or IgM deficiency, if they have Evans syndrome, and are being treated with rituximab, or if they have an underlying primary immune deficiency. And it can take time to have a response, so really you don't want to use this if you have a patient who's acutely bleeding, because it does often take weeks to see a response. And the long-term remission rate is really less than with splenectomy in these patients who get rituximab. And so it really is a temporizing measure. It's not the long-term cure that it once was thought to be. And for that reason, the most recent American Society of Hematology guidelines actually recommend TPO receptor agonists over rituximab or splenectomy, particularly for pediatric patients. The TPO receptor agonists, there are 3 that are currently FDA approved in the US. 2 of them are approved for use in pediatric patients and have been approved for use for a long time, actually. Romiflostim and Altrombopag are both approved for patients who are down to 1 year of age. And Altrombopag is oral, Romiflostim is sub-Q weekly. They're all effective at increasing the platelet count with durable responses of 50 to 90%. And they usually increase the platelet count by about 2 weeks post reaching an effective dose. And this is a little bit limited by dose escalation. And so you might take a little longer than 2 weeks to get there if it takes you longer to get to that effective dose. And many patients with romiflostim require doses around 3 to 5 mics per kilo, and Altrombopag generally somewhere between 50 and 75 milligrams daily. The TPO receptor agonists do have downsides. Rimiplostim is given subcutaneously, often in a physician's office, at least at first, although we can get home administration approved for many of our pediatric patients. It's not always easy to get that done for adult patients. And L-Traumapag has significant dietary restrictions. These are mitigated with avatrombopag and doesn't have those dietary restrictions, but that is a newer drug and is not yet FDA approved for pediatric use. These are expensive medications and are not available everywhere. And it's not curative therapy or even an attempt at a curative therapy. In most cases, the platelet count will return to baseline or even have a rebound thrombocytopenia within 2 weeks of drug discontinuation. Although with longer term administration and keeping that platelet count in a closer to normal range for a period of time, there is some evidence for immunomodulation with remission seen in some patients. Oops, sorry. Let's go back. One more. All right. And then finally, talk about splenectomy. So splenectomy is successful therapy in many patients. The remission rate is about 70%. There are no consistent predictors of response. It does result in a loss of immune protection, which can be reduced with vaccination and antibiotic prophylaxis, but that risk remains higher, is especially high for the first 2 years post-splenectomy, and then remains higher than baseline, as far as we can tell, lifelong. There are vascular complications that may be associated with splenectomy. These are mostly seen in other hematologic disorders, but there may be an increased risk of thrombosis or and stroke and MI associated with splenectomy. So it's a little bit, it's certainly hard to recommend splenectomy early on in disease unless you have out of control bleeding in most pediatric patients, especially because those patients have a high probability of eventual remission. And so I think with that, I'm going to stop talking and open it up for questions. Please put your questions in the chat or in the question box, and we're happy to take your questions.
Thank you so much, Dr. Lambert, for that insightful presentation. I also want to encourage everyone to submit your questions via the chat box in your control panel. We do have some questions already there. And Dr. Lambert, I'll ask you, how do you measure immature platelet fraction? How is it done at your institution?
So it's actually part of a extended platelet panel that we have on our CBC, and so we just asked them to do a platelet profile. It's part of the part of what we can get on our machines. Your lab has to have a Sysmex machine. There is another type of machine that can give you an estimate of reticulated platelet count as well, but if you just have a Coulter counter, you're not going to be able to get an immature platelet fraction.
Great. Our next question is, how often do you identify any meaningful, actionable information from additional immunologic workup in chronic ITP patients?
Yeah, I got to publish this paper actually, because we did look at our patient population, and almost 50% of our long-term chronic ITP patients had additional actionable secondary diagnoses. Either they met criteria definitively for celiac disease or lupus or CBID, or they had an identifiable immune disorder when we looked hard enough for those things. And so we now screen everybody on a yearly basis when they have chronic ITP, starting somewhere between 1 and 2 years post their diagnosis.
I would say that's our experience here too. And I think another aspect of that too is revisiting that question, as you're saying too, periodically, that the immune phenotyping changes over time. And so what was normal, maybe when a patient was younger, earlier in their course with ITP, becomes changes over time, and it may become more clear what the underlying immune issue is in the patient. And in addition to that, new genes are discovered as part of immune dysregulatory pathways. And so those panels keep expanding and identifying, or kind of going back, if someone had whole exome sequencing, kind of going back to that periodically to see if some of the newly uncovered genes might be one that explains the patient's underlying immune defect.
We routinely reanalyze molecular testing every 2 years, actually.
In your patient population, when do you consider bone marrow evaluation?
When the smear is abnormal. So if I see abnormal red cell or white cell morphology, if they're developing a macrocytosis, if I have a patient who fails to respond to splenectomy, and I'm going to be in there doing a splenectomy, so they're going to be under anesthesia. Well, so if I have a patient who is getting a splenectomy, I will often do a marrow at the time of splenectomy, because they've clearly failed to respond to a bunch of therapies before then, and they're going to be under anesthesia at that time anyway. So we'll do a marrow with splenectomy. And then if the patient fails to respond, we might repeat that marrow, especially if there was any evidence of hypocellularity or anything at all that was not totally 100% normal on that initial marrow. I don't do very many. I'll be honest with you. I think I can count on 2 hands the number of ITP marrows I've done in the last 5 years.
How about patients who fail every therapy you've tried, or some number of therapies? And then what's your number?
If I'm thinking about chemo, if I'm headed to daratumumab and belimumab and like all of the new chemotherapy, or if I'm giving them vincristine or something like that, then I think about a marrow, because I'm going to treat something else. Then I'll do a marrow.
In chronic patients, do you look at an ANA test and refer to rheumatology if the ANA is strongly positive, recognizing that it's a little bit case by case, but what's your general approach?
I do a yearly ANA, especially in adolescent girls, and I have a pretty low threshold to send them to rheumatology and add in things like complement levels and other stuff like that to support a lupus diagnosis, especially in adolescent females. But we look every year after the first 1 to 2 years of ITP. What do you do?
I do the same thing. So I screen. I mainly screen every year, though, in adolescents more than in the younger patients, where maybe have looked once but don't necessarily screen every year. And I also have a low threshold for sending patients to rheumatology and kind of co-managing, thinking about the role of hydroxychloroquine in patients. And I often don't send kind of expanded antibody panels routinely in patients with ITP or Evans, and leave that to the rheumatologist if the ANA test is positive, which then they'll often be screening those labs as well on an annual basis.
Yeah.
Another question here is, what should be the platelet count goal when you're treating with a thrombopoietin receptor agonist?
So that depends a lot on why we started the TPO receptor agonist in the first place. If we started it like in that case of the 7-year-old with really bad fatigue, I don't know that I would have a platelet count goal in mind. I would really be thinking about, is he feeling better? And then, if he's feeling better and his platelet count's 30,000 and he started at 30,000, I don't know that I would necessarily call that a failure. because he's feeling better, and that's why we started the medicine. If we started it because his platelet count was 10,000 and he wanted to play ice hockey, then I want his platelet count, you know, something reasonably higher, and I would call it a treatment success if he hit that platelet count target, 75, I don't know, 100, I don't know, for ice hockey, something like that. If he's bleeding and we started the medication because he's bleeding, then I want him to stop bleeding. I don't care what the number is. So I want him to stop bleeding.
I have the same approach, and I think it is a little bit patient specific. Generally, you're aiming for lower than the normal range. So oftentimes, generally, you're ranging for somewhere between 30 to 150 in terms of the platelet count. But I think too, for my patients who are athletes, which there seem to be so many patients who are athletes and have ITP, sometimes I tolerate a little bit of a higher platelet count because it bounces around on these medications, so that if someone's generally between 100 and 200, that's a tolerable range, rather than kind of letting them have low dips that may interrupt their season or their ability to play in tournaments and things like that. So it all really does depend on their activity level and what their symptoms are. There are two questions that I think are so important to clinical practice, both about coverage and success with insurance in terms of immune phenotyping and in particular genetic testing, and kind of what is your approach to that and being successful in getting this testing done in this patient population?
Yeah, so I am very, very lucky that I have a genetic counselor who works with me. And I think having a genetic counselor who helps write the letter of medical necessity really makes a difference in the probability of getting that genetic testing approved. I think just having their signature on the letter makes it more likely that the test is going to be approved. But it's not easy. And what I put in my letter of medical necessity is I make sure to talk about how diagnosing an inborn error of immunity will alter management, and may identify a need for hematopoietic stem cell transplant. And if you put transplant on the table, that almost always gets the testing approved. I think, so I don't mince words. I'm just like, this kid might need a transplant. I honestly don't know until I get the genetics back. As far as immunophenotyping, I don't often have a hard time getting that approved by insurance. The only time I've had a difficulty getting it approved is when I'm being incredibly stubborn about having it done at my institution versus someplace else. But if I'm a little agnostic about where it gets done, then I think we can usually get it done.
I think there's a question about this too. One thing that is helpful, I think, in sharing with colleagues is having sort of templated letters of medical necessity, because we're basically asking for the same kind of testing in very similar patients. So, you know, kind of finding that language that meets success, and then sharing that so that can be used and people aren't kind of reinventing the wheel. And somebody asked here if they could get a copy of your medical necessity letter, which I do think that's the type of resources we should all be sharing with each other. Why should each of us reinvent that wheel? And I think also there's the letter of medical necessity for doing an inherited thrombocytopenia panel. You know, it's a different list of things that you're looking for, but also so important to outcomes with, you know, some genes with malignancy predisposition and needing different monitoring. So I think it would be nice if we could all share that and kind of know what the magic words are to get success on the first try.
If you want to email me, I can share it.
Great. And then along the same lines too, another question was about the ethical dilemma of genetic testing and inherited platelet disorders and identifying genes that might predispose to malignancy, and the struggle in families that have no history of malignancy and mild thrombocytopenia, you know, whether to go down that path and the decision-making and discussion about that.
Yeah, I mean, that is a conversation that is had with the family and the patient. So I don't routinely recommend testing for an inherited thrombocytopenia that includes a cancer predisposition in children who are not young enough to participate in the conversation. I try really hard to temporize in families that are insistent on genetic testing, because sometimes people will come to me because they want genetic testing in a very young child. So I will try to temporize because in most cases, these things are not going to manifest before the child's old enough to participate in the conversation. And I think that they deserve a voice in that conversation.
Great. There's another question here about the evaluation of isolated thrombocytopenia and what kind of platelet flow cytometry studies you were mentioning earlier would you suggest as part of that algorithm that you showed, where there's consideration of an inherited platelet disorder? You mentioned flow cytometry testing.
Yeah, so I will look for 2B3A expression and 1B9 expression on the surface of platelets and document whether those are normal. And I have identified patients with Bernard-Soulier syndrome by flow cytometry where it took a while to identify the genetic defect. And sometimes it's hard to get platelet ags in those patients. Or the platelet ags are not as definitive. We also identified a patient with a LAD3 mutation, so a Kindlin FERMT3 mutation, who presented with tons of mucosal bleeding and we're just having trouble getting platelet eggs that made sense. And so he had absent 2B3A expression, which is, you know, what you would expect. And then we identified the mutation, but we were able to take that abnormal platelet flow cytometry and use that to justify molecular testing.
I think on the flip side of that, with the genetic testing, it can be challenging sometimes to figure out if a variant of uncertain significance is meaningful, and the functional assays or platelet staining, different kinds of platelet testing can be difficult to obtain, that there are different tests available potentially in the research setting that are available in the clinical setting, or there are labs of expertise, but maybe it may not be feasible to send a sample to that lab because they're out of the country. And so I think it can be challenging to kind of get to the final answer that you're suspicious for something, that there's a variant, but there isn't something to help you determine whether it's truly pathogenic in terms of a next level of test.
Yeah, and I think family testing helps sometimes in those cases, and a lot of times the good genetic labs will do at least parental testing to help you identify and sort families. But for recessive traits, it's a little bit harder, even with genetic testing necessarily, to nail down that whether or not that variant really matters.
I'm not sure about mentioning a specific lab on this venue, but I wanted to mention, going back to the conversation about primary immunodeficiency panels, that the Invitae lab has a panel, and they've just made it, I believe, a primary immunodeficiency panel that it could be of no cost when you're looking for one of those disorders. And so that might be something to look into for people whose patients, the insurance won't cover it, and there's a large cost associated with it that's not possible for a family. I don't know how long that'll be available for, but that's a potential resource. And they keep adding genes to their panel that I think
up to 500 genes.
Over 500, right? Yep.
And I will say that that panel can be free, but or reduced cost, and has a pretty good turnaround time. So it's often our go-to if especially if we can't get approval to do an exome or do something else.
Great, thank you. I think that's all the time we have for questions today. As a reminder, you'll be able to review this program for your reference. Please contact Catherine Cantu Aguino at her email address, which hopefully you have, to obtain a copy of this recording. I want to thank Dr. Lambert for her very informative presentation and for her insightful comments, and thanks to all of you for your excellent questions to have this great discussion here at the end. The Foundation is pleased to provide this program at no cost to attendees, and you'll receive the evaluation immediately following this program. Please complete it, and then we'll send you information regarding CME credits. We'd like to thank SOBI once again for supporting the program today. The next case conversation session is slated to be held later summer 2022, so be sure to check out the website for more information. And if you haven't done so already, please note that early bird registration is still open for FWGBD 2022. It ends on June 1st, so please be sure to register today. More information about the conference can also be found on the website. Thank you for your attendance today, and we look forward to your future presentation and Foundation programs.
Thanks.